Welcome to Speaking of Midwives, the official podcast of the Journal of Midwifery and Women's Health, where we bring the pages of the journal to life. I'm your host, Melissa Avery. Each episode, we go deep into the evidence, spotlighting the researchers, the breakthroughs, and the midwives leading the science that is transforming reproductive health care. Greetings and welcome to Speaking of Midwives with the Journal of Midwifery and Women's Health. Today, we are speaking with Dr. Elise Erickson, midwife and associate professor in the Department of Physiology, College of Medicine at the University of Arizona. We are talking about her article, The Role of Passive Descent and Epidural Analgesia in Outcomes Associated with Prolonged Pushing Among Nulliparous Individuals in Midwifery Care. So Elise, let's welcome. Thank you so much for joining us today. And let's start by first having you just describe a little bit about your midwifery background for our listeners.
Yeah, absolutely. Thanks, Melissa. And thank you to the journal for the invitation to come in and talk a little bit more about this work. I know it's a topic we deal with in care and in various settings, and it's an ongoing opportunity to continue to, document midwifery care and the impact it can have. So just a little background about my midwifery journey. I have been a midwife for 21 years. I obtained a BSN from University of Michigan and went like a beeline to midwifery, master's degree at the University of Illinois, and was inspired greatly by numerous midwife researchers and other nurse researchers that I had been exposed to over those years, and knew pretty quickly and sort of with intent that I would want to pursue research and an academic career in addition to providing care. And so that's sort of what happened. There was a circuitous path, so to speak, of getting there. But I studied did some graduate work in neuroscience in Chicago, and then finished a PhD in 2018 at Oregon Health and Science University. And so that was a wonderful opportunity from an education standpoint, but also because of the faculty practice at Oregon Health and Science. And so, which was helpful in being able to engage in secondary analysis and other types of research to document midwifery care outcomes. So since then, I've moved to Arizona and to Tucson, and a lot of the work that I do is based on the physiology of parturition and other aspects of maternal health that are physiologically informed. And so I've been embedded in this department and growing research program in a number of different ways. So this paper we published some time ago, and was the effort from, let's say, from a DNP students project is how it got started.
Well, actually, I was going to ask you next about what led to your interest. So that's part of it, but you have a deeper interest in this topic in this work.
Yeah, I mean, my primary research focus is a lot of it is on oxytocin function and uterine contractility and maternal morbidity related to hemorrhage, and thinking about ways of personalizing birth care in that sphere. I use genetic and epigenetic data to try to help us understand people's responses to oxytocin. So anything in that sphere of how the body is getting safely through labor and birth is really of great interest to me. But this particular clinical question came about because one of our DNP students at OHSU, one of our first classes of DNP students actually, was setting herself up for a project and was, observing that on our unit, there was a lot of hubbub about, midwives have these long second stages and, blah, blah, blah. There's all this, concern. And sometimes that concern is because when we need to involve an obstetric attending, it's because we've done everything we can do, and now it's time to go to the next stage. So the cases that they see are the ones that ultimately need other intervention, whereas a lot of the other ones that were also equally long did not. And so, you can become informed by what is in front of you, and if you don't see the whole picture. So this effort was started as a DNP project to look at what are the outcomes associated with, long second stage? What's the documentation that's going on? And so it was originally intended to just look at practice patterns and improve documentation, communication, et cetera. But through the process of needing to make sure we had really good data to be able to do that project, it became obvious that this was also an opportunity for research and for publishing and to share this with a broader audience.
Yeah.
So that's how
Well,
I ended up here.
yeah, it's great. And just as a side note, you interestingly highlight the opportunities and what can happen when people with different sorts of terminal degrees get together. Somebody looking more at practice, someone looking more at research, and partnering together to get
Yeah,
to do studies that help us
entirely.
in practice. So that's a great example.
Yeah.
So can you just a little more precisely talk about your for this work that was resulted in your article being published, a little bit more about your precise aim in conducting the study? And I agree with you, it's such an important issue because midwives that practice in hospitals think about second stage and descent within the situation of epidural analgesia all the time.
Yeah. Yeah. And it's interesting because I don't know. I feel like I've worked in a lot of different hospital settings, and what's okay in one part of town is not okay in another part of town sometimes, or one state or another state, or this is how we do it here, quote unquote. And I find that very interesting considering we're all, humans coming into this birth process, and your body doesn't work differently because you're on the north side of town versus the south side of town, but
That's
whatever.
right.
Or country to country, which I can talk about a little bit later as we think about what the literature as a whole is saying about passive descent in the second stage. Um, so I can give a little backstory for how we have access to this data. And a lot of midwifery practices do benchmarking. They record their, individual patient level outcomes, client level outcomes, and then report them in aggregate about their practice. At OHSU, we had been collecting hundreds of variables, data on hundreds of variables, starting in the entry to care visit, and then through intrapartum and postpartum. And primarily that was around benchmarking, but it became obvious that we were collecting all of this information, but a lot of it wasn't actually being reported in benchmarking because there were other questions that people were bringing to the table. In an academic setting, a lot of people have interests and want to be able to probe what's happening in the practice. And it's also useful just for, internal benchmarking, midwife to midwife, et cetera. And so through this process of collecting data in paper form and then eventually transitioning to a REDCap database, which is online, interface where you can just enter data, and then there's, nice branching logic built in, so you don't have to fill in the variable if it doesn't apply. And so we were able to adapt that. And so it's prospectively collected data, and we were collecting very, very intentionally when was, full dilation noted, when was active pushing initiated, what was the position of the baby at the time of delivery, the head position, and a lot of other associated variables. And so it was a keen opportunity to be able to make use of data that had been collected in real time. So it's being recorded at the time of delivery. You're not going back usually. I mean, with rare exception if there's like some missingness, but and then you can ask these questions of your own practice, and what are the trends that you have, and how can you then either defend your outcomes if need be in a system, or communicate some of the nuance to a wider audience. So it has a lot of value, and a lot of people are doing benchmarking, and so it's a great way to be able to document midwifery care.
Mm-hmm. Can you share a little bit more about a gap in evidence that you identified? And you talked about this in the article where you said there was a gap in our ability to understand differences in practice between midwives and obstetricians in terms of second stage management.
Yeah, that's a great question. So I don't think I really answered your first question, which is the purpose.
You're doing just
okay.
fine.
Well, the purpose really was, as I mentioned, DNP project initiated at first, but then as we think about it from a research perspective, we just want to describe how many people have a prolonged second stage. And then what are some of the characteristics that may be associated with and or contribute to that prolonged second stage, so we can better understand what things might be modifiable or not modifiable, and then also to provide better counseling. Because if we know what our data are showing in our own practice, then we can turn around and say, okay, here's our benefit risk ratio of continuing on for another hour, for example. Okay, so that was the purpose of the study. But what came out of this, and in writing a paper like this, you have a ton of data, you have a lot of things to say, but then you have to think about, what does it mean? And one opportunity for future research, I think, is that we have these chunks of time that are documented. We have the start of, full dilation, we have the start of pushing, and we have the birth. And then there's a big mystery in that gap of time, or that span of time, right? There's ways of approaching the birth process. There's ways of managing second stage that probably vary greatly from person to person, provider to provider, um, discipline to discipline. But we don't know a lot about what is happening. We know what we're doing as a practice, and so we could reflect on that. And we suspect that there's a lot of, it's not just, count to 10 and push, right? There's a lot of conversation. There's negotiation of different positions. Is the baby going to tolerate that position? Does someone need a rest? Is the baby not tolerating it? So now we need to push every other contraction. Are we dealing with psychosocial issues, or history of trauma and needing to kind of face those fears? How are we navigating, let's say, the situations when pushing isn't effective in a certain position, and then we have to switch. So there's a whole lot of decision making that's going on in that span of time. And too often, I think a lot of these studies reduce it down to, well, you pushed. The person pushed, right? But that's not all that's happening. So there's a huge opportunity, I think, for people to get very descriptive about what's actually happening during that course of time.
Can you add a little bit about, as you were planning the studies, you sort of moved on from the initial project you described and decided to go further. What was known at the time about the balance between optimizing outcomes and reducing harms as we think about the duration and the nature of, as you said, second stage labor?
Yeah. So the problem with a lot of maternity care research is that the temporal order of events is not often recorded. So there are these broad associations between, for example, receiving an epidural in labor and a prolonged second stage or a longer pushing phase. There are the, associations of longer second stage and operative vaginal delivery, or just operative delivery total. There are associations with chorioamnionitis. But in terms of management or optimal management, it had been at the time, and at the time when the data were collected, which was 2012 to 2019, it was very normative to labor down, for a period of time. And for some, it would be, an hour-ish. That's sort of arbitrary. But that was what kind of was normative. And so then pushing would commence, and then, you would move along. But also in that same span of time, there was a larger study being conducted, a randomized controlled trial of immediate versus delayed pushing called the OMSS trial. And that was getting ready to be published during this time. We knew that it was going on. And so it actually was published before we published our article. And so we can put it in context. But at the time, from 2012 to 2019, most people were, if someone didn't have an urge, we'd wait a little bit, and sometimes wait a lot of it, and if you look at the charts in this article, you'll see that the range of passive descent, there's some people on the high end of things. Yeah, it's impressive actually, when you sit and think about it, like what was happening in that span of X number of hours where there was no pushing going on. Clearly there was a reason, right?
Right. And what was it? Well, would you just briefly remind our listeners the benefits of collecting prospective data, which you had the benefit of having, and also you had a data set representing almost 1,500 records of nulliparous
Mhm.
parturients?
Yeah, so the benefit of prospective data collection, it goes back to kind of what I was saying earlier on. You can validate that information in real time. And if you're the one who was attending the birth, then and you're writing down what happened or clicking the boxes, kind of like you do in the electronic health record and whatnot, ideally it's correct. And you can validate it very quickly because you're checking it against the electronic health record, and hopefully it's recorded in, a reasonable fashion that it will optimize the accuracy and limit the missing data. The other part of it is that you can plan how based on what you want to know and on the back end, if you're prospectively collecting this information, you can design the way you ask the questions to be really optimally useful. For example, the timing of epidural placement and all the things that come after it. That's oftentimes what we see as a problem in a lot of these studies is, there's epidural and prolonged second stage, but you don't know for how long was there an epidural in place? For how long was labor persisting before the epidural was placed? A lot of those questions are unanswerable in current data sets. So if you're ever thinking about, what are your dilemmas in practice, designing the data collection tool to be useful is actually something you have to spend some time and think about. Um, so yeah, so we did end up with a fairly large sample for this one practice, and 1,500, about just shy of 1,500 nulliparous births. Now, I also want to say that this was limited to people who did reach full dilation and had some pushing. People who were needing a C-section prior to labor, people needing one during the course of labor but not reaching second stage were obviously not included in this sample because we were looking at pushing. So we started with a sample of 3,500 and whittled our way down to the 1,400 or so, because we also excluded multips. Most feeling we're not as interested in pushing phases in multiparous folks, though some can have long second stages, but by and large,
Usually easier.
we're less nervous and jerky about that because we want to prevent that primary C-section, right?
Exactly.
So the nullip is like the opportunity to optimize, really.
Exactly. No, that's great. Thanks so much. So your primary predictor was more than 3 hours of active pushing. So can you just talk a little bit about the choice of that variable?
Yeah, we hemmed and hawed, actually.
Oh,
What?
interesting.
Well, should it be all second stage? And we could go back and redo this analysis and use that variable. But the way that prolonged second stage was defined was by the active pushing, definition. So greater than 3 hours for a nulliparous person is what was defined at the time. And given that the passive phase was not based on a protocol, it was individualized. People would engage in passive descent for a whole lot of reasons, and it was very individual circumstances related. So we felt like that was a more challenging variable to include in that whole bundle of the duration. So it's important to pay attention when you're looking at the literature of like, what is your definition of second stage? Is it everything altogether, or is it just the active pushing part? And so we've broken this down in the paper with a number of figures that show, for example, the passive phase relative to the active pushing phase, and then the passive phase relative to the whole duration. And so there's some interesting figures in there if you're curious.
Yeah. Yeah, I'm sure people will want to look at those if they haven't had a chance. So can we start? Let's talk about what you found out. And let's start with just the key overall descriptive results that you would want to emphasize for our primarily clinician audience.
So before, yes, I can provide that. But I want to give a little not backstory, but a little bit of background on who these folks are that we're reporting on, because that's always important to consider
Right.
too. We're in the Pacific Northwest when we're, collecting this data. So we're reflecting, the folks in that environment, which are predominantly folks who identify as white or have European ancestry. So it's about 90%. And most were in that 39 to 41 week range. So, pretty bundled around that, full term period. And the mean BMI for this sample was 24 before pregnancy. So I think it's important to consider that there's generalizability factors that, just because it works this way in, Portland, Oregon, doesn't mean it's always going to work that way in another setting. However, the midwifery group had a very, let's say, cohesive approach to attending, second stage and labor and birth. And there, it felt like we could really reliably state that this was a generalized approach of personalizing the second stage, that there was very few like protocol-driven interventions aside from after 4 hours of second stage, we did it by policy, do a consultation. And so there's an inflection point around 4 hours where a lot more C-sections happened.
Sure. And a consultation with your obstetrician colleagues.
Exactly. Yes. So aside from that, it's not like it was mandated that we had to do second stage one way or another. Okay. So the key takeaway, the primary aim was like, well, how often is second stage prolonged, right? It's just a very basic question. And it's 16.9% in our sample. So out of the 1456 folks, 247 of the births were considered prolonged by the definition of more 3 hours or more of active pushing. And so there was an interesting range in that, and also the passive descent and the active pushing. So I'll just kind of give you some range of numbers. So in terms of like the passive descent factor, it ranged from 34 minutes, it was a mean of 34 minutes, but a maximum we reported of 12.58 hours. We had a person who had passive descent for 12 hours. There's about 1 in 10 of the births that we attended in this practice would be a community birth transfer.
Mm-hmm.
And so I don't know who that person was particularly, but there were definitely those situations where there had been, a long like lag between, one, let's say, location of care or place of care into another. So that's an interesting data point, and I love seeing that person on the figures because they're way here. But overall, passive descent that was greater than, let's say, 2.5 hours was only 5% of the whole sample. So that was actually a really rare, very kind of outlier sort of person. Active pushing ranged from what we would say 0 minutes, meaning like the baby just kind of fell out, to 9.75 hours. So our
active pushing,
9.75 hours. So, but the median, so that nice, where is it in the middle, is 1.3 hours. So not on average or in the middle of the pack, very typical, right?
Yeah, no, that's pretty consistent with textbook, average first stage or second stage for a first time.
And the other thing to note is that the epidural use in this whole sample, I'm going to have to look for, I think it was about 50-60%. So, kind of split in the middle there, which is helpful. That's unusual for data sets, unless it's a midwifery-led care practice. Usually the epidural rate is going to be more like 80 to 90%. So it gives us an opportunity to compare between groups, right?
Right. Okay. So could you talk a little bit then? You had subgroups. And can you talk a little bit about that particular analysis or those analyses and what you learned from those that would be that our clinicians can learn from?
Right. So because I'm looking at it now, it's like 54% of folks used an epidural. So 787 were using an epidural during their labor. So when we looked at the let's say the active pushing greater than 3 hours or prolonged pushing phenomenon, we see that there's a much greater representation of prolonged pushing in the sample of folks who received an epidural. And that's probably not terribly surprising. Other things that were associated with prolonged pushing were needing oxytocin during their labor at some point. And then, let's say, a longer mean first stage of labor as well. So none of those are terribly surprising. Greater intra-amniotic convection or choreo was about 11% of those who had prolonged pushing versus only 5% of those who weren't prolonged. The other thing that was commonly observed for those who had prolonged pushing was that they were less likely to be in an OA or occiput anterior position at the time of birth. So 95% of babies that were born for those who only pushed less than 3 hours were in OA, but only 80%. So, a pretty substantial number who ended up being born in a non-OA position were, affected by that prolonged second stage. So those things like walk together. So it makes
Right.
sense. So
Yeah,
it's kind of telling us
absolutely.
what our data would be expected to show. The other thing, for those who ended up with prolonged second stage, 26% needed a C-section in the end, or delivered via C-section in the end, and about 10% had an operative vaginal birth. The other really important takeaway is that for those who had the prolonged second stage, 17% ended up with an obstetric anal sphincter injury, versus only 6% of those who had not prolonged. So those were some really important like secondary outcomes that we were interested in, because you have to balance the risk of 100% going forth with a cesarean birth, which is clearly a major abdominal surgery, versus the potential risk for having a major injury to the anal sphincter. So, what's that benefit risk ratio? And that's often a conversation that needs to happen after you've been pushing for a few hours and deciding, okay, should we keep going? What are the benefits? What are the risks? And so it's very helpful to clarify that number, that it's not just this kind of nebulous, well, it's somewhat increased. If you keep pushing, you may have a more severe laceration, for instance. So those were some of the just general associations with prolonged pushing. We did also take a look at looking at within the people who had an epidural and comparing between those who had normal pushing versus those who didn't. And we did the same thing for those who did not have an epidural. So we kind of broke this apart into several pieces, because, what happens a lot with these kind of large, let's say, cohorts or population data sets is that we try to control for all of these factors. But in the end, you're dealing with discrete groups of people that have specific characteristics in common. So people who have an epidural should probably be compared to other people with an epidural, if you're trying to understand, this combination of a prolonged second stage and in the setting of an epidural. So those were some choices that we made to be able to look at it. And so there's a lot of data in here as I was rereading it. Like there's a lot in here. That's my occupational hazard, is I want to give all of the information, even if it can be a little overwhelming. But so we took a look at those differences, and what stands out, I think the most is, I might find. I actually want to pull up this table so I can be sure that I'm presenting this correctly. But I think what stands out the most is that there were some key differences in the type of pushing that people were engaging in, and that people who were not having an epidural were more likely to be, non-directed and spontaneous, right? Reflecting kind of that ability to sense what's happening and kind of guide your own pushing efforts when someone is not having an epidural in place. And the other thing that was interesting is that prolonged pushing between those who, or let's say within those who had an epidural or without an epidural, the rate of OAC, or the obstetric anal sphincter injury, was actually the same. So when you had prolonged pushing, that was a risk for this outcome. Epidural itself didn't change that. So that is somewhat reassuring, I think, that just because someone has an epidural, you're not more at risk for a more severe laceration, but you were more at risk to have prolonged pushing. So you have to kind of take it all in context. But there's a lot of factors that might lead to that more severe injury. And then the other, I think, key outcome that we spent some time looking at, because we had been receiving feedback about like excessive blood loss and what are the risks to the newborn and all of those other, safety parameters. We actually didn't see a lot of more severe blood loss based on the prolonged pushing. And newborn outcomes were relatively the same as well. They were more likely to have, let's say, a greater than 500 milliliter blood loss. But a lot of that is also tied to the need for a C-section, which was more common both with epidural and also with prolonged pushing.
And did you say earlier, because now it's been a few days since I've read it, but
Yeah.
that it was 28% among those that had epidural and the longer second stage, greater than 3 hours of active
20
pushing?
for the C-section,
The
right?
cesarean rate.
Cesarean rate. So there's a couple tables here. So let's go back and double check what that rate was. The rate between active pushing across the whole board, so that's 247 folks, 26.7%
Okay,
needed a
26.
C-section
Okay.
versus 2.2% of people who didn't have active long pushing, so prolonged pushing. But then when you look within the epidural subgroups, things look a little bit different. So if someone had an epidural and prolonged pushing, their rate went up to 31.8%. So that's the 60 out of 189 within those who had an epidural. For those who didn't have an epidural but still pushed a long time, their rate of C-section was 10%.
Okay. Yeah.
So it still increased if you didn't have an epidural, but the magnitude of that was greater.
Yeah. Well, as you said, there's a lot in that paper. There's a lot of data, a lot of results. So if you were to kind of think about the primary implications of that study for our colleagues that are in clinical practice, what would you share with them as the best things for their own practice?
So the other aspect that we haven't really talked about was the role of passive descent, because even though it wasn't a policy to do X, Y, or Z, for I would say it was very common for people to just have some passive descent and hopefully wait till someone is starting to feel an urge. Now, for people without an epidural, that happened very quickly. Passive descent was very limited, which makes sense because
Sure.
also you're documenting full dilation in someone without an epidural, probably because they're saying, I need to push, right? Not because you're routinely checking someone just for information's sake, at least
Right.
not in this practice.
Yeah, absolutely.
With someone who's not having an epidural. Now, for someone who's having an epidural, perhaps there would be just sort of a random check and like, oh, you're 10, great. And there's no urge to push. So perhaps in those settings, there would have been a delay or some passive descent. But there was no routine for, let's say, check every hour, check every 2 hours. That didn't exist. But this observation that we made of those who used passive descent for what we characterize it as 1 hour or more versus less than 1 hour. And again, that's an arbitrary number, but we had to kind of draw a line in the sand to be able to make these comparisons. And what we found was that the association between prolonged pushing and passive descent kind of went together. So when people had longer passive descent, in many cases, they also had longer active pushing. And probably you could imagine if you're waiting for someone to have an urge to push and you're waiting longer and you're waiting longer, it's probably because the baby's not rotated enough, that it's somewhat large. Maybe there's other circumstances. It's very dense epidural. Like there could be a lot of reasons why you'd be waiting longer for active pushing to engage. And then that sort of went alongside with that active pushing in this sample. So So even though prolonged pushing with or without passive descent was associated with higher odds for cesarean, the magnitude of the effect. So what I mean by that is that there's an association between prolonged pushing and C-section. But when people had longer passive descent, the risk of C-section was lower than when they had no passive descent and then ended up with a longer prolonged stage, second stage of active pushing. So we think of that kind of statistically, we talk about that as an effect modifier, in that when you introduce this extra variable and we look at this intermediate stage of passive, passive descent or kind of waiting for that urge to kick in, that allowed for a reduction in the risk for C-section in these data. So again, it's not a policy that we were saying, okay, everyone has to wait an hour, but it's what we observed in the data. So I can give you some numbers. So labors with prolonged pushing were 18 times as likely to end in C-section than those without prolonged pushing. That's not a surprise to anyone. But for those who had at least an hour of passive descent, the odds for C-section were 7.1 times as likely. So it's reduced quite a bit. There's still an association. You can't negate that. But it's less of an association because probably something happened in that passive descent window that allowed for a better alignment, changing of positions, waiting for stronger urge, all of those potential things, which we didn't characterize. We weren't in the room, checking the box every 5 minutes, like, what are you doing with this person? That would be an interesting study.
It would. It would.
Yes. So I think that's one really important takeaway, because there's a lot of debate as to whether or not passive descent actually helps improve or could potentially improve the odds of a vaginal birth or not. The other key takeaway was that when you're talking with people about the risk benefit once you've been pushing for some time, in our study, the risk of OAC was definitely higher with prolonged pushing. And that, the use of passive descent seemed to, it wasn't protective, let's say, for the OAC outcome. And we could potentially attribute that to, maybe there was malposition in the baby, or maybe there were characteristics of that person's skin integrity or tissue integrity that were going to be an issue no matter how long that second stage was. But it was definitely associated with that, with the prolonged active pushing. So you can counsel people that, here's our odds of this happening versus the odds of this happening, potentially, and use real numbers to be able to communicate that.
Yeah, helps people understand a little bit better to have some more of those data. Yeah.
Yeah, I think so.
So you talked a lot about there not being any, I'm just going to say rules, but any specific ways that people were required to handle some of these situations at your institution in the midwifery practice where this study was done. Given that, and then given your results, do you see policy implications from this research at the local health system level? Or lack thereof, perhaps?
So I think that, after that, I mentioned there was that randomized trial that came out called the OMSS trial. And what that study observed was it was 1,200 participants in one group, immediate pushing, versus 1,200 in another that was instructed to wait 60 minutes and then begin pushing. And they didn't see any impact or benefit for C-section differences. And they documented that there were some potential risks of waiting, including some increases in hemorrhage risk, and then also rates of choreo. And so in light of this randomized trial, because we often think of these as the gold standard, this is, how we then go ahead and set policy. I know of institutions that have had a real pushback against anyone laboring down anymore. And what I would offer is that, we all know that randomized trials have their flaws when it comes to application in real world contexts. And that in the setting of this midwifery-led practice where the care was specifically individualized to the context, that if someone is just saying, well, we're going to labor down on everyone, the data from that RCT didn't suggest that that was helpful for improving C-section. However, when there's a documented issue going on, this baby is posterior, this person doesn't have adequate contractions, there's psychosocial factors, there's fatigue, there are other things that we would like to try to optimize before we start pushing. I think that those should be part of a conversation and could be something that is brought up in the context of person-centered care. So from a policy perspective, trying to not write policies that negate the ability to personalize care, I think is really important, which can be hard for some people who want to bundle everything and standardize checklist all aspects of care, but you lose that person-centeredness in the process and you lose the context. I mean, if you have someone who's dead asleep because they're exhausted, I mean, you can wake them up and say, they're going to push now, but what's the likelihood that that's actually going to be successful? Would it be better to let them take a 30-minute nap or an hour nap and then wake up and be rejuvenated and ready to go? So, thinking about that, and the other piece that comes out of this, I think, is just documenting what your rationale is. If you're choosing to labor down, why? Does a person have an urge to push? No. Or we've tried some pushing and it wasn't successful. We're going to take some rest and we're going to, do what we need to do. So, that being said, so you were talking about policy. There's a new study that was just published in the American Journal of OBGYN, and it's out of France, and it's 10,000 births attended by midwives in France. And in France, the policy, talk about policy, is to have passive descent for up to 3 hours and potentially even up to 4 hours before engaging in active pushing. And they have documented that the outcomes associated with that were actually quite robust and quite safe. That there were, very short active phases of pushing, like under 15 minutes for, folks that were permitted to labor down or to do passive descent for up to 3 hours. So this study was just published, I think, this month in AJOG, and I encourage you to take a look at it because it really flies in the face of that randomized trial of the OMSS one. I think now they did not, this is really just reporting vaginal delivery. So they were not looking at C-sections in this study. So that's something I see as a little bit of a limitation of it, but it does speak to the possibility that, we started off this talk thinking about, well, you can do one thing in one setting across town and not in another. Well, I don't think vaginas are different in France, that they can tolerate 3 hours of passive descent there, but it's impossible to do that here. So I think replicating this type of an approach might be really useful in an American setting as well, particularly because we have like a slightly older parturient population, and being on the older side is associated with longer active stage of pushing and potentially more malposition. So maybe we need to be a little more permissive. We need to try to optimize that rotation and descent through that process. So it's just something to consider.
Yeah. Thank you. That's helpful. And we'll add that study to the list of things available to listeners to make it available to them as well. And of course, you talked about this earlier, but I know you're thinking all this in the context of how that fetus is doing in there along the way as that decision making is going on. So you talked about another study that just came out, which is a great lead into what else do we need to know, from the work you've done? What else needs to be done in this area to help guide our clinical practice a little better?
Yeah, what else needs to be done? So there's that big gap in knowledge of this isn't just the passage of time. We're not, I mean, sometimes midwives are sitting on their hands in the room, right? But a lot of times they're in there doing, various position changes, doing specific types of coaching for someone who might be reluctant to push or dealing with fears or traumas. I think that there's a lot of need to document what is associated with a successful vaginal delivery where second stage is challenging. No one debates that if you get a strong urge to push, the baby's at a +2 and you push for 12 minutes and everything's fine. It was like, okay, great. It didn't matter what you did. You could have stood in the corner, right? But it's the times when in this like 16% of our cases where, okay, we're all sweaty here, like my hands hurt. We're doing the tug of war, and everyone's there trying to really help and support. So what are the characteristics that are associated with the most successful difficult second stages, right? Instead of comparing them to the ones that were really successful because or that were easy, quote unquote, that's I don't know that that's terribly helpful because we're not learning anything new. Okay, yeah, more babies that are OP are likely to be born after a long second stage. Okay, we know that. We know that it's associated with Corey. We know it's associated with big babies. But what are the things that are happening in those settings where the babies are big and malpositioned and mom's got a 40-year-old pelvis and all of these things? How can we optimize those outcomes? And that's where my interest goes immediately. And so those are the studies that I think we could probably do from a midwifery lens very, very well. And it really lends itself nicely to a mixed methods where we're understanding the experience of the care provider and the person giving birth and the family around them, the nursing support, all of those things, and the quantitative. When was pushing commenced? How long had that epidural been in place? How long was labor before then? What was oxytocin doing? Like, were we augmenting? How high of a dose was it? All of these factors that are influencing really the power of the push. So, there's a lot of room here. So, if someone's looking for that type of an opportunity or they have a great data set that they could just add some detail to, this would be a really brilliant opportunity to expand that knowledge.
Great. So can you summarize your message to our listeners and colleagues?
I think so. Prolonged pushing, as we all experience and know, is not uncommon. And that there are, person and birth characteristics that are commonly associated with them that we can document here. What the role of passive descent in the pushing phase is in a person-centered practice may be protective for vaginal birth or against a cesarean birth, but you have to balance that against the risks that someone may experience an anal sphincter injury. And so we have to be transparent and offer, data to folks as we're dealing with these situations and to weigh those benefits and risks, and to be able to speak transparently about them. But I would also suggest, offer that everyone who's doing benchmarking is in a position to be able to, let's say, advance this science further by just taking a look at the way you're capturing that information. And I think we can really build our knowledge base if we can come together and to pool data from across a whole variety of places, because this is really reflecting the Pacific Northwest and one particular practice. And what we need to do is to look across the whole country and the diversity of our patient population and the practice patterns and the settings that we have. So it's a piece of information, but I think it's also a call to action.
Well, that is a great place to end. Thank you so much, Dr. Erickson, for an engaging and very informative conversation about passive descent and epidural analgesia. And thank you to our listeners for joining us on Speaking of Midwives. Please join us the next time. Thank you for joining us on Speaking of Midwives, brought to you by the American College of Nurse Midwives and the Journal of Midwifery and Women's Health. If you were inspired by today's conversation, connect with us through ACNM's channels. The Journal of Midwifery and Women's Health is at jmwh.org, your resource for cutting-edge midwifery and women's health research. See you next time.